the things we've been focused on at the National Healthcare for the Homeless Council is that intersection of the healthcare system and the homeless services system. And we're right there at that intersection. And of course, this community knows the overlap between victims of domestic violence and their families and homelessness. And so I think there's a lot of communities right now that are trying to figure out how are we serving very vulnerable at needs populations so that they are safe and both from a health perspective and from a safety perspective. And so one of the things in the calls that we've been having with continuum of care providers and lead organizations in the country is people are really struggling with how to identify appropriate isolation and quarantine facilities, and then how do providers know what those referral and transportation protocols are. And so I think right now, as people are just presenting with symptoms, we've got a healthcare system that is does not have wide access to testing. There's a widely differing approach to screening, both in shelters, a little bit more consistent in the healthcare field, but shelters are just kind of doing a lot of different things. Right now, HUD is working on releasing guidance for shelters to do screenings, and so we hopefully see that in the next few days. And then CDC is also actively working to get out guidance for outreach and unsheltered populations. So if we've got folks who are living in encampments, we really want to make sure that we've got good guidance for not only how to do outreach in a way that's appropriate, but also making sure people aren't getting cut off from services. And I think that's the big thing right now is we're very concerned that in this time of crisis response, people aren't able to see their healthcare provider for all of their ongoing medical conditions. And as we all know, diabetes doesn't wait, stroke doesn't wait, relapse, it doesn't wait. And so I think one of the things we're trying to figure out in the healthcare community is walking two priorities right now, making sure there's access to care and make sure we're able to keep people safe in an infectious disease environment. And so we're moving to doing as much as we can via telephone, and for people who that may not be a safe space for some folks. They may not be in a place where they can confidentially and safely talk to their provider. If people are at home, we all know what the risks are there. And so we're really just worried about losing contact with our patients who are in vulnerable situations or putting them at risk inadvertently with all of the public health guidance. So a couple of things that we've been focused on is working with our local response structures to make sure that people who are homeless and people particularly who are not safe in the home space that we're telling them to go, that they make that population a priority population. And that particularly for our folks in the homeless space, it's a combination of factors that's creating this high-risk group. One is that there's really high levels of poor health and underlying medical and behavioral health conditions, and then acute illnesses that are just part of our everyday. That combines with most of our patients getting their services pretty much all in congregate settings, whether that's public transportation or soup kitchens or health clinics or shelters. A lot of that is very crowded and congregate. And so it's exactly the kind of place where we're asking people to do social distancing, and that's just not possible. We're seeing a lot more aging and elderly in our population. And so in the healthcare for the homeless space, last year we served just over 1 million patients, and 40% of them were over age 50. And so that brings with it added risk factors. And then I touched on this earlier, but what does it mean to quarantine at home, wash your hands, distance yourself from others, disinfect your living space, when you don't have the ability to follow that, when you don't control the environment you're in? And so thinking about how are we really asking people to do things that they just can't do. And when we think about like encampments, for example, very rarely do encampments have access to the kind of hand hygiene or toilets or trash pickup or anything that we're asking people to do. And then finally, I think the conversation isn't an honest one unless we're talking about the stigma and discrimination that communities often put onto vulnerable populations, and make that very difficult then for response structures in the event of an emergency to already be poised to serve this population. in many ways, response structures do everything they can not to serve this population on any other day. And so when it comes time to have an emergency, what do communities typically do? They typically push people to the margins. And that is not only not obviously the best plan for people, but it's also now not the best interest of our public health. So we're focused, so that's just the combination of factors that come together to make this a high-risk group. We're focused on 5 different policy actions for local response structures. One is first and foremost, where will people go when they need isolation and quarantine? And this is not what individual providers need to be coming up with. This is not within the scope of our ability. These need to be community local response decisions made in collaboration with healthcare and other homeless service providers so that we identify where people can go and have that be appropriate space. We also are looking at a lot of policy actions to prohibit evictions and foreclosures, prohibit encampment clearings, making sure we're able to continue healthcare services, just making it so that people aren't further destabilized. This is an opportunity, if your state has not expanded Medicaid, to really push that hard, because Medicaid is a program that really can be of great utility, not only to the people we're serving, but also to the state systems that are needing to pay for this. And so thinking about how are we making the most of the flexibilities in that program to allow us to do more telemedicine in a more flexible way, making street outreach and street medicine a billable service, making sure people are able to get 90-day supplies of medications so that they don't run out. So all of that. A third area is expanding shelter capacity and absolutely understanding that encampments are not shelter and shelter is not housing. But to the best of our ability, how can we be spreading our shelter capacity so that we can do social distancing and continue to deliver those services? Fourth is, and we probably are all in this boat, critical lack of supplies, not just cleaning equipment and personal protective equipment, but also things like thermometers and just swabs, things that we need as healthcare workers, because we need to be protecting both our workforce and the clients that we're serving. And then finally, we're really focused on medical respite care programs, these programs where folks who need ongoing medical care but aren't ill enough to be in the hospital, where do they go? We all know that unsafe discharge to public parks or to shelters don't do well, and then people land right back in the hospital. So how is this an opportunity for us to do a medical respite care programs in our communities that either can be for COVID-involved people who need testing or came back with a positive test, or medical respite program space so that we can protect really vulnerably ill people from those who may be COVID involved. And all of these are decisions that local communities should be making that works well for what their community need is. And so with that, that's an overview of what we've been working with and what we're seeing on the ground. And so I'll turn it back over to you for the next speaker, but I'm happy to take questions.
Well, hi, I guess I'll go ahead and jump right in here. Can everybody hear me? This is Linda. I'm seeing nods. I'm Linda Olsen with the Washington State Coalition Against Domestic Violence. And it seems like it was just, well, it was just a couple of weeks ago when I heard about the first circumstance, the first person who tested positive for COVID-19 in the country was just in my backyard right here in Snohomish County. And so things have been just cycling ever since. Barbara, thank you so much for all of that valuable information. And one of the things that we at the coalition have really been working on is both communication as well as connection. The communication aspects have been, of course, trying to develop a team. Jake Fawcett is the head of our little team at Wiskative so that we can check in on information, get all of the resources, and we've got a web page site right at the beginning that pretty much outlines the resource roundup, and that changes practically hourly. As you heard from Barbara, and we'll hear from other people, it's a changing situation, and it can be really stressful when we don't know, we don't have a good handle on things. And as a result of some of that uncertainty, the other big thing that we at our coalition, and I'm sure other coalitions are also trying to do, is that connection. We appreciate our connection. We appreciate being able to talk to each other. One of the best parts that I've enjoyed about that is each of our staff members at the coalition divvied up our membership list, and we're all doing outreach calls. And we're hearing directly from people, what are you doing? What are you concerned about? How can the coalition help? And so through that, we've been planning webinars and conversations so that folks can share information, share questions, feel connected to each other, and know that in each corner of our state, the circumstances are very different. From King County with its explosive population of people who are testing positive and deaths, all the way to tiny counties in Eastern Washington that really still aren't quite sure what the big deal is. So we've got the range. We're working on being connected together and getting great information like this webinar is intended to provide. So I will pass it on to the next person at this point.
Great. Thank you, Linda. It's always so good to hear from you. My name is Suzanne Marcus, and I'm here with my colleague, Chris Billhart, and we're from the National Alliance for Safe Housing. And we support organizations and communities to ensure that survivors have a full range of safe housing options. We have a long history of developing and managing safe housing organizations and programs, but this is uncharted territory. And the information we're sharing with you today comes from what we're hearing from advocates and what we know that they're doing in the field, and from what we know is innovative practice that still prevails, especially in challenging times like mobile advocacy and survivor-driven advocacy, flex funding, and the like. We're learning with you, and while we don't have all the answers, we and our DVH-PAC colleagues are here to support you and to be your partners as you think through the many challenges that are going to come up for you daily, if not hourly. So today we're addressing some of the questions pertaining to domestic violence, sexual assault housing programs and trafficking housing programs, their operations, services, the residents. And for folks who were on NNEDV's call with the coalition on Tuesday, this information may be a repeat for you, just an FYI. So I'll start by talking about some of the questions that we received about what procedures should be put in place to protect current residential clients. And here's what we suggest based on what we've been hearing and what we know. First is to follow CDC and state health department guidelines, minimize staffing.
Suzanne, I think we lost your audio. No, I'm going to send you the call number. Maybe Chris can jump in for a minute.
Sure, I can. Oh, are you back, Suzanne?
Can you hear me?
Yeah.
Okay, I have no idea what happened. I'm so sorry. So should I start from follow CDC and state health department guidelines? Did people hear me say that? Okay. Mm-hmm. Minimize staffing to minimize in-person contact. Practice social distancing, so cut out house meetings and support group gatherings if you can. Increase disinfecting procedures and focus on laundry area in particular. Wash hands, encourage residents to do the same. Amend usage of communal space, playrooms, living rooms, kitchens. Don't place single women together in a room or mix families in a room if you can. And we encourage you to post a notice to your residents and talk with them about the fact that you're not a medical facility, that you don't screen for illness, and that you can't guarantee that this facility is illness-free at any time. You can't now, nor could you ever. Now I'll turn it over to Chris, who's gonna talk a little bit more about screening and questions around COVID specifically.
Yeah, and thanks, Suzanne. And I would just like to also add a note about posting information in other languages. And I'm sure that we've got stuff trickling down from the feds that will be helpful with that, but be thinking about the population that you serve and making sure the information is accessible to them. And so I'm going to move to questions that providers have brought forward about how to respond to residents in their shelter facilities or residential facilities that may be sick, how to get access to the COVID-19 test, and requests for how to meet the challenge of a potential need to quarantine in a communal living situation. So here, it's really important to remember that we are not, some of us may be, but generally we are not healthcare workers. And so it should not be up to the shelter advocate unless we hear otherwise that we're being commandeered in this way. It shouldn't be up to the shelter advocate to do an official screening for COVID-19. And so just like we do with many other things, what our role is to advocate. So we may need to advocate for the survivor, with the survivor, to get in touch with their primary health care provider. If they don't have a primary health care provider, contacting the State Department of Health. And testing availability, I wish we had the magic wand about making tests readily available to everyone. I just heard from somebody in my family who's been exposed in New York City that because she's not in a high priority population, she doesn't have access to a test. And so this is really going to vary from community to community, and it's evolving, as we keep saying, daily. And so finding out what's going on in your community, we've heard everything from, drive-up testing spots in Walmart parking lots to no tests at all being available, even when they're requested by people that are showing symptoms. So this is something that we may have limited control over at this stage in the game. If a resident wants to be tested, assisting them, finding out what that information is, what's true in your community, and helping to advocate with them, for them with that. And Suzanne kind of already talked about some of the daily precautions that can be taken, but I think to demystify it a little bit, thinking about any resident who may have the flu or another communicable disease. So frequent washing, demonstrating, how to wash your hands for 20 seconds. You can count 1 Mississippi, 2 Mississippi, or you can sing happy birthday twice is what I've heard, provides the adequate time. Using masks if they're available, isolation as much as possible, particularly if somebody appears to be sick. So all the things that we would do if somebody has the flu or some other communicable disease in our shelter or residential programs. Some programs may be able to alter services to provide safety in hotels or alternative housing than the communal living setting, especially for folks who need isolation or quarantine. And I know that there are a lot of communities that have arrangements with local hotels for that kind of need, maybe not this specific kind of need, but when the shelter is not available or adequate for that person. And making sure to talk to your funders to ensure that it's allowable. Having those conversations with funders when there's ever something different that you're going to be doing as far as how you spend your money and how you run your program. Those transparent conversations with funders can be really helpful. Also consult with them if you have any questions about trying to make a plan about cutting down the number of residents in your housing. If you feel that that's necessary, open communication with them about that. And negotiating about the flexibility to use funds for those different forms of sheltering. So those are just some of the kinds of things that we're hearing questions about in the field. And back to Suzanne.
Great, thank you. So these are some questions that we've received about incoming and potential shelter residents. There are many questions about what to do about screening incoming shelter clients, such as should incoming shelter clients be screened for COVID-19? Programs want to know if a shelter has the right to refuse to do an intake if someone tests positive. And does a shelter have the right to refuse to do intake if someone has been exposed but is not symptomatic and needs self-quarantine for 14 days? So again, program staff are not medical professionals and are not in the position to screen. Programs technically have the right to refuse to conduct an intake. So FIPSA language states, quote, these provisions are not intended to deny a shelter the ability to manage its services and secure the safety of all shelter residents should, for example, a client become violent or abusive to other clients. So technically, almost anything a shelter decides to do to secure safety for shelter residents, they can do. But of course, we do not emphasize this and instead emphasize try everything else first. So what that might mean in a situation like this is, can you use your flex funding to help the survivor find a hotel stay or to stay safely in their housing? How can you employ mobile advocacy to help the survivor feel connected and advocate with the survivor that way? And not to just assume with no empirical evidence that someone is in automatic danger. For example, this comes up all the time with boys over 12 and that assumption that that would somehow create danger in a shelter situation. So again, try not to make any assumptions about the health of a survivor, because as we know, with COVID, people can show no symptoms and still be a carrier. Chris, back to you.
Okay, so a few questions that we've been hearing about the organization's ability to change services. I addressed this a little bit a minute ago. Some advocates are asking if the program can go ahead and decide to close its shelter. And I think we heard from Barbara about we're at a point in time where expanding shelter is probably more on the mark. However, in terms of that question for you all, the basic answer to whether you can close your shelter just based on your own decision is no. You can't decide to just close your services. When shelters have done this in past emergencies, there have been examples of programs who get their funding cut off because the shelter service that they're supposed to be delivering has not been delivered. So that's a risk that you could take if you just decide to close your shelter. You'd be breaching your contract if you just stop services with no accompanying approved change of scope from the funder. So the funders are your friends. Get on the phone and talk with them about those kinds of questions that might be coming up in your own planning as your response. Other questions have involved things like services that might be provided out in the field, like hospital advocacy that many programs provide, or other in-person services. Again, checking with funders. Given the circumstances, it's clearly reasonable to propose that you provide services in an alternate way. So maybe instead of in-person hospital advocacy, you'd be providing phone or video-based services. So we have the sense that a lot of those kinds of requests, given the circumstances, are going to be approved, but have that conversation. Other programmatic changes to consider, some of the examples of things that programs have shared with us that they're already doing, really beefing up the phone contact, the 24-hour availability of hotline services, having more advocates available to provide that phone and video consultation. So you may be shifting your staffing pattern to make sure that there's more folks that can respond to folks over the phone and through video chat, rather than the in-person services they might normally provide. Doing one-on-one advocacy with the 6 feet of distance, the social distancing that we're all being advised to employ, to provide maybe across a picnic table or just a little bit farther away than usual, keeping that social distance. Using hotel instead of shelter when that's possible. And we also want to re-refer you, if you haven't, if you've already heard this, or if it's new, to the NNEDV's digital toolkit, or consult with the NNEDV folks, their safety net team, to ensure that you're safely using a digital service delivery. So folks that aren't familiar with using technology in their advocacy would definitely get a lot of support through accessing those resources at NNEDV. And as Suzanne said, consider pausing support groups, house meetings, and moving to a digital format if that's possible. So if there's a weekly house meeting, normally hold several meetings with a smaller number of folks so that there's more physical space between people. And we realize that we've probably just touched the very tip of the iceberg. So again, we're happy to receive more questions and see what we can do to target our support to the complicated world that we're all facing right now. So that's it for me. And I forget who goes next.
That makes it my turn.
Okay.
All right. Hi, everyone. Alicia Aiken here from the Danu Center for Strategic Advocacy, and most of you more likely know me through Danu Center's Confidentiality Institute. My role here, I'm going to talk a little bit about mobile advocacy, picking up on the NNEDV safety net support around that. And I'm also going to talk about confidentiality. But I want to start with, how do I put this? The folks that we work with are in crisis 100% of the time, right? Like, this crisis is scary, it is new, and it feels different, but we have values and principles and mechanisms from which we start when we work with folks in crisis, because we do this every day. And what I have found helpful in this situation is to take a breath and lead from those values and those principles. If we are set up as a space to house people for whom their home is unsafe, that's what we do, right? And if there are issues that present themselves that we need to address, like they might have a fever and we don't want to expose the other people, we figure out how to do both. And we reach out. There's been a great, some great ideas on the chat about folks who have been getting support locally, for instance, from the United Way Disaster Relief Fund to fund getting people into hotel rooms where they can be isolated, whether it's because they are a vulnerable person or because they might be experiencing symptoms that we don't know what it is or is not, because there aren't sufficient tests out there. But we're going to lead from, we house people who are in crisis for whom their homes are unsafe. In the same way that I'm housing somebody right now who's in crisis, who is from New York City, which is the epicenter of the pandemic, right? And their housing was shut off, closed down because because of the crisis, and they were sent out of the city. I am housing them right now. I didn't blink, I didn't think twice. I didn't test them, I didn't check them for a fever. It's my son, right? We're gonna do the same thing for the people who come to our doors. Okay, so how are we going to do that? We're going to think about mobile advocacy, and we're going to start from privacy and access. We are trying to get privacy and access. This is a time where survivors might be making choices themselves to share information over systems that they would not have chosen to use in the past, but it's what's available to them now. We want to help them make informed choices about what to use. We want to help them to understand what the pros and cons are of reaching out to you on FaceTime versus a telephone call versus a text platform, right? So we want to help them to understand what's possible. I'm not going to get into a super amount of detail on this because there's a lot of stuff that we're working on, and there is a phenomenal tool for all digital services, but it's got updates specific to dealing with this pandemic And you can find that at techsafety.org, the Digital Services Toolkit. We're sending out the links to that. That's got a lot of detail about how to think about providing mobile advocacy services in normal times and in these times. So go to those resources and pay attention to them. But remember that survivors can choose for themselves what platform is safe to share with you. And then when you respond to them, you can make choices to minimize disclosure risk. You can make choices that you clear whatever data storage records you have the ability to clear. You can remind them to clear their data storage records. You can just, you use the products in a way that provides the best protection that is possible. A lot of questions are coming up around confidentiality. So let's start from the survivor's need for privacy doesn't change in a situation like this. In fact, it might get greater. We are not receiving any direction from the Office of Violence Against Women or HHS, which oversees FIPSA, or the Office of Victim of Crime that says follow lessened privacy protections. So we are going to focus on what we've always focused on, which is survivor-led disclosures. We only share survivor information when the survivors say, I want you to share this because it helps me. That's what we should have always been doing. If you're suddenly realizing that your systems might have been designed differently, then this is a great moment to pull back and get back to our values. That's we do survivor-led sharing. I know that there's a federal rule that says that you must have written consent. That term written is not defined in the statute. We have always made a lot of assumptions that written has to mean you're sitting in front of me and you sign a form in ink. But we have always adjusted that to make accommodations for people, whether they be disability-based accommodations or access-based accommodations. So what we're talking about right now is we're talking about waits, right? A good advocate waits for proper authority before sharing a survivor's information. What does wait stand for? It is written, but that just means something in writing that you and the survivor can both refer to later. Something in writing that you and the survivor can refer to later. We have lots of digital resources for producing something in writing that you can refer to later. Approved, something that you have some record that the survivor approved this. Yes, this is in writing and it is what I want. I've seen it and lawyers would say adopted it, but regular people would say approved it. That might be that the survivor sent it as an email or a text from their phone number or their email account. And you can confirm that they're not being impersonated. This is sort of an important one. You can confirm that they're not being impersonated, but you have some way of showing that they've approved it. So written, anything in writing you can refer to later that they've approved it. Informed, you've had an opportunity to have a discussion about the pros and cons of you sharing their information. Reasonably time limited, it's just achieving their goal. What is the amount of time necessary to achieve their goal? And survivor centered and specific, right? A good advocate waits for proper authority before sharing something. So that proper authority sometimes might be a requirement from a statute or a requirement from a court order. We've been getting a lot of questions where people are saying, now that there's a national emergency, does that mean we don't follow confidentiality and we report COVID cases? Unless you have a statute in your state, which some states might have a statute that depending on the organization that you're in and what it's doing, you might have a state statute that requires you to report infectious disease. But most likely what you're doing is advocacy to connect people to healthcare, right? Advocacy to connect people to healthcare, whether they've already got healthcare and they're not sure how to connect with it, you help. If they don't have access to healthcare and you help them access it. And then healthcare workers are in a position to do the public health work of reporting and monitoring and investigating COVID-19. You are not healthcare workers, and we don't need you to be in this crisis, healthcare workers. We need you to be advocates in this crisis. And so that's how you want to think about, am I suddenly mandated to do something if there is a statute or a court order that requires you to do it? And you wait to find out whether or not that has happened before you start sharing information. If you get a demand and you're not sure what to do, you reach out for technical assistance to National Network to End Domestic Violence. The Safety Net team can help you to manage that. let's see, I want to make sure I covered the stuff that I said I was going to cover. If you have somebody in the shelter who is either having symptoms or we discover has tested positive, and there's something that we want to communicate with the other people in the shelter, but we can communicate by saying there is someone in the shelter who is experiencing symptoms. There is someone in the shelter who has tested positive. We don't tell them the age, the gender, the room, the location. We do not tell them whether it's a staff person or a resident, or frankly, somebody who came in to help maintain or clean the facility. We tell them that someone who has been in the same place as you has some symptoms. So all the cautions we've been asking you to observe and talking to you about observing, there are triple reasons to observe them and to be super clear. That does two things. It gets the information out without without disclosing identifying information. And the second thing is it tells other people that if they have symptoms, they don't have to be scared to tell you, because you are going to respect their privacy when they tell you, so that you can then manage it well. I'm going to take, I'm sure, more questions about confidentiality and advocacy questions, but I want to, for now, I want to sort of pass it on, the baton on to the next person.
Okay, thank you, Alicia. I appreciate that. So I'm Jill Robertson. I am a program manager for Collaborative Solutions, and just wanted to give you some resources today from a HUD perspective. Some of you have various HUD grants, and so wanted to just make sure that we help you get linked to those as well. So I'm going to try to share my screen. I wanted to talk about a couple of things. Let me try to get to the appropriate location here. All right. So just wanted to share, this is a landing page, and it is one of the first things that HUD did when COVID-19 started surfacing and started becoming a very hot topic and a great concern for all of us in our communities. So this particular landing page is actually a webinar, and if you scroll down, you'll see there's actually an opportunity to listen to the webinar and provide resources for your teams and possibly for your staff, other staff as well. Just want to highlight that Barbara, who's on our call today, was also on this particular webinar and provided some really great information. So I commend that to you. I also want to, I'm hoping I can just, you can see this next thing. This is, HUD has started some COVID-19 planning and response office hours, and want to just make sure that you all are aware of that, that HUD is hosting office hours, and we have links to tomorrow. They are hosting office hours. So if you happen to have a COC grant or an ESG grant, and you have questions specifically about the resources and what you can do with them, just know that there is an opportunity, and we'll make those links available to you. And then I want to talk specifically now about some of the resources that you all might have. And I'm sorry, I've got to kind of navigate around here. Okay, so some of you might have ESG funds, and I just wanted to make sure that everybody was aware of some of the guidance that HUD has put out recently, reminders to people that if you run a shelter, that these, in this middle section here that talks about shelter operations, there's lots of opportunities for changing your funding around, or if you need to get supplies, whether that's bleach or disinfectant wipes, or even if you need to get a repair to equipment, that through your ESG funds, you can do that. I did have a question earlier today about people not having enough money in their operational budget. It's relatively easy to do a grant amendment change for ESG. So I just really want to encourage you to talk to your program officer that's overseeing your ESG program, whether that's at the city or state level, and they will certainly help you to make those adjustments. But this is some good resources that are available for you, and just want to make sure that you know about those. And then lastly, I want to talk briefly about the Continuum of Care funds. So some of you have Continuum of Care funds. I do want to mention quickly here that unfortunately this really is not relevant for those of you, well, in some ways it might be relevant for those of you that have the DV rapid rehousing funds. But if you have a permanent housing project or you have something that has supportive services in it, then there are a lot of options for you, that ways that you can use your funding potentially during this crisis. That would include helping with basic things like food, water, medications, various transportation needs. So again, hopefully you have some of those things already in your budget line items, but if not, your local CPD office can help you with that. And if you have any questions, I'm sure that we can help you navigate how to get in contact with the right person. And we're here to help you with any questions you might have. I'm going to stop sharing and pass the baton now over to Debbie Fox.
Thank you, Jill, and thanks to everybody on the call. I'm so glad so many people could join so quickly and we could have this conversation. I've been looking at the chat, the Zoom chat box, and I'm just very inspired, and that was kind of one of the goals of the call, was to bring everybody together to be able to talk to one another and share ideas and get really creative in the field about what's happening. So I'm finding a lot of inspiration from that. And then also I just want to highlight again what has been said on the call, and what Lish mentioned is just kind of like the groundedness of our field. And I think, you know, there's the self-care piece and what we're doing in this work to take care of ourselves and how to do the work effectively. And something that's been very inspiring to me is to think about, there was a point in our field and in our work where this issue was not addressed by the general public, and people were ignoring it. And there were people in the domestic and sexual violence movement that moved to mobilize and address an issue that was not being acknowledged originally. So I feel like we're in at a unprecedented time, but we also have a lot of history and people in this work to draw from that did create systems out of nothing. So we're, I think, at a place in our world and in our country right now where we're having to get creative and do kind of mutual aid sort of things and sharing resources. And so that gives me a lot of hope. And so, yeah, there's a lot that's happening on the community level. And then, of course, obviously, we want things to happen at the federal level, and we want our government and the federal folks to be responding and addressing this issue and getting resources out to people that we serve. And then also, we want to make sure it's getting out to us as well, because there's a thin line between crisis for those who are vulnerable, but then also crisis even among our own families and the people that we love and care about when people start losing jobs. And I think, yeah, like from a personal example, like I helped my niece and nephew and my niece and her boyfriend like figure out how to apply for unemployment and food stamps. So these are the times when the federal level responses as people are losing their jobs and being laid off, that we definitely need those resources and want to encourage us to be using them and encouraging the people that we care about in our communities, survivors, and all of us to be accessing that. So I'm going to get into the policy wonky weeds a little bit more. And I just know a lot of information has already been shared with everybody, and it's a lot of inundation on top of the news and everything else we're thinking about. But I'm going to get a little wonky. So it's kind of like take a deep breath, and I'm going to throw some information out at you and take it as you will, because it's going to be a lot. Because even for me at the federal level and working with our policy team and other national policy folks, it's really hard to keep track, and it's fast and furious. It's like, is the president going to give us $1,000? Are we going to have test kits? Is what's good? You know, like we all at every minute are trying to figure out, like, is this thing happening? Are we going to get some resources? So I feel like there's good news happening at the federal level. People are working literally around the clock. Some of the people that I work with are just 24/7 coming up with things and pushing things through Congress. So there's a lot of people working at the National Task Force, which is a coalition of national, tribal, state, and local leadership organizations that are working with Congress to address the needs of domestic and sexual violence survivors and the programs like you all that serve them to the response for the coronavirus. So we're busy in DC working on a third stimulus package to address survivor needs. There was a couple other bills that people might have heard about that there were not specific housing or survivor needs, but there's a third stimulus package that we're trying to get money in there, and we're educating people on that. So just to be clear, because we're federally funded, this is not a lobbying ask. I'm not asking you to go lobby. I'm just educating you. But you're welcome to go visit the nnedv.org website. There's more like take action-y kind of things. But for this is just information sharing about what is being talked about at the federal level. So the latest update from Congress is the Family First Corona Response Act, FFCRA. We can still joke about acronyms now. So we have another new acronym. So it passed the Senate yesterday, and that is going to be signed by the president very soon. And so the bill addresses many of the needs of low-wage workers, which obviously includes a lot of people that we know and people in our field. And it supports many survivors by the broad economic protections that are within it. So just taking out like a few highlights from the bill. It will increase WIC and emergency food assistance programs. It will allow the Department of Agriculture to approve state plans for emergency EBT transfers. It increases funding for senior nutrition programs. It will provide school lunch waivers. It'll suspend SNAP work training requirements. I want to applaud for that, like with virtual applaud. Allow states to request waivers for SNAP maximum amounts, as well as flexibility in caseload management. For employers, this is important for y'all as employers and employees. It expands family medical leave act for employers with fewer than 500 employees, and government workers have been on the job for at least 30 days to take up 12 weeks of job protected leave, and that could be a mix of paid and partial pay. It provides emergency grants to states for unemployment insurance. It provides emergency sick leave for up to 2 weeks for things directly related to the virus. And it does provide some tax credits to employers for leave. Please don't ask me about employer tax credits. You'll have to talk to someone else about that. So, so that's what has already passed and will be signed by the president and should be going out to folks shortly. So that's some economic relief. So that bill was considered phase 2 in a 3-phase process around the stimulus package. So Congress and the administration are working on a third stimulus package that will provide relief to COVID-19 and its impacts. All right, I feel like we should all take a breath here because this is so much information. And we'll send this out too. I know there's a lot of asking of like if we'll send out the info, and we will. So just so people are familiar, there was a phase 1 of the stimulus bill that was $8.3 billion, with a B, $billion that focused on coronavirus vaccine and research. Then there's phase 2, that's what passed yesterday and that the president will sign. That's the Family First Coronavirus Response Act that's largely focused on economic and unemployment and sick leave benefits. And so then phase 3, which is what we're working on now, really fast and furiously, will be much larger than both of those other bills. And it's bills where there will be specific initiatives to support housing and homelessness programs generally, and then domestic and sexual violence programs are our field specifically. And so then we'll be sending out a link so you don't have to memorize all this, but Politico does a great breakdown of like, here's how the process is working. And also if you kind of want to be educated for your friends, as your friends are kind of like, when's that $1,000 going to come? So you can be able to talk to them and also encourage them to like, go get your unemployment benefits now and all those sorts of things. We're working with our national partners to influence phase 3, which is the housing and the DV portion of that. And we're working with congressional staffers to address the needs of survivors. So some things that we're working on is to increase funds for housing, increase flexibility, and reducing administrative burdens like match waivers, which wouldn't this be amazing if we could get rid of some match waivers right now and give a lot of respite around that. And we're looking at trying to find flexible assistance to get money directly to survivors. And our policy shop and the National Task Force is also working on the full recommendations, and we'll send out an email and information about it shortly. So the specific asks, the top level asks, are to provide support for victim services to operate shelter and house survivors with increased flexible resources. So we want Congress, we're requesting Congress to increase the federal funding streams, including HUD's emergency solutions grants and disaster housing funding. We are looking to increase the Violence Against Women Act Sexual Assault Services Program by 100 million, because as we know, with disasters of all kinds, including public health, increased risk for violence and violence against women and sexual assault does increase. So there's a $100 million increase there. We're looking for an increase in Family Violence Prevention Services Act by 100 million, VAWA transitional housing by 40 million. We're have HUD Continuum of Care bonus funds at 100 million. VAWA culturally specific programs for underserved communities and underserved populations by 20 million. And we need an increase for the domestic violence hotline at 2 million. And just to be clear, these are asks and things that we're putting out there. It's not happened yet. So what I described with what has already passed with the Senate and the president will sign, that has happened. These are just requests now that they have not, the money has not gone out the door and nothing has been voted on or signed. We're also looking at trying to increase VOCA funds to meet a variety of victims' needs and asking Congress to deposit into the Crime Victims Fund from the direct penalties and fines from the federal deferred and non-prosecution agreements to be deposited into the Crime Victims Fund. That was very wordy, so I apologize for that. So we just want to ensure in the field a lot of flexibility by eliminating match requirements for all the VOCA, FIPSA, and HUD Continuum of Care funding. Something that I'm worried about for the field, and we've just been thinking about a lot, is like reducing documentation requirements during this time. What does it mean to be doing all the reporting and all the administrative burdens and the paperwork that's required? We want to get these funds to people who need housing and support quickly. So how can we slow down? How can we minimize some of that so we don't have to slow down the access to funds and get them quickly so people can have rent assistance right away? We are allowing all funds, we want the allowing of all funds to be used for temporary individual accommodation such as hotel or motel while securing permanent housing. I think there's been a lot in the chat room and really creative innovations that are happening around people brokering deals with hotel motels, because there's empty hotel and motels now that people are not traveling and we're all grounded for the time being. So we're hoping that we can, if there's an ability to use those funds to shift to different types of housing accommodations and partnering with different housing folks. Also, we really want to ensure that there's enough funding at the federal administering agencies to hire staff. So we're looking at our, we're all in this together, that our federal workers have enough staff to ensure the funds get out at all different levels. So, and then also at the program level, because we just know with increased funding, then there is increased management of those funds. So just making sure we have enough workers to be able to do all the things to get the money out the door. And as was talked about earlier in the intro, we know that DV and sexual assault does disproportionately impact women and women of color and people who are disproportionately represented among low-wage workers and service workers who are being laid off at high rates, and that survivors need very specific economic protections to ensure that they can live independently of their abusers, and especially in times like these of crisis. So we're asking that the temporary assistance to needy family, that assistance is critical right now for survivors, and that we want to improve access to TANF by increasing drawdown amounts and waiving work restrictions, instituting a moratorium on TANF sanctions and terminations for the duration of the crisis, and allowing additional TANF payments for emergency assistance. And then this is the one that I think gets the most buzz, and the phase 3 in this phase, this future stimulus package does include direct cash assistance to individuals. So that's you, me, and everyone you know. So Congress must ensure that the distribution of there's a plan that survivors who are in undisclosed location and people who are experiencing homelessness, who are living on the streets, have access and can gain that money. So if anyone has a plan, this is where we're all in it together. Like we can't quite figure out like how we're going to distribute it to people who are unbanked or not don't have an address. So we want to make sure that this money gets, this direct assistance cash payments get to those people most in need. So if anyone in the chat box or in our field has an idea, email me, because we're all kind of buzzing around about that, trying to figure out how to do that. Finally, we want safe paid leave to address legal, health, and counseling needs related to the violence they have experienced. So that is a lot of information. There'll be more emails and information as the days go on about this package. There's other pieces as well that will benefit us all around improvements and economic improvements. I just wanted to do the top level ones that would be impacting the survivors in our field. I think that's it. I just encourage you all, to take care of yourselves during this time. I'm reminding myself and the people around me I know to eat, drink, sleep, and, to do the basics and make sure we're taking care of ourselves first and getting nourishment, and then, just staying healthy to do this work, and that we can all do it together, and we're all in this together, whatever role we play in the system. And we're working really, really diligently at the federal level to try to get more resources on the ground, and hopefully we can have more conversations like this as a field, and just keeping each other informed of what's happening and what you're doing in your different states to address all these rapid changes that are happening in our lives. So I'm thinking of everybody, thinking of you all, and just glad to be here today with everybody. And I think I'm passing it over to Linda for a closing, and then we're going to open up for Q&A.
All right, thanks, Debbie. And that was an amazing offering of not only information, but of hope. Thank you to everyone at NNEDV for the great policy work that's happening. And we'll all keep our fingers crossed that those different packages come through so that survivors and our own staff will benefit from that. Just the continuing comment about connection. And Debbie, you said it so nicely as far as communicating, connecting, talking to one another, learning from one another. It is so important in this time that we take a minute to do that, to reach out to each other, to stay calm, and also to hang on to that compassion. I loved what Alicia said related to treating everyone you see as if they were your son. They're all our sons, daughters, siblings, the people we love and care about. And sometimes we aren't always the most gracious, wonderful people when we're stressed, tired, cranky, but to take that breath and to stay calm and focused, and remember that these times also bring out the best in all of us, ultimately, and being able to, again, remind one another of that, and take care of each other, just as I think we've all been saying in so many wonderful ways. Thanks to all of you for the great work that you do, from our coalition to everybody else across the country. And I think now it's time for questions, answers. Is that Christy?
Me.
Carla.
Carla. Yep. Thank you so much for that, Linda. That was beautiful. Yeah. And I want to echo the thanks for everyone for sharing and for being open and for sort of being in community with us. So I have a couple questions that I'm going to go straight to Debbie for. They're really around sort of funding. And while it's fresh in your head, someone was asking about funding for IT, not TA, equipment during these times. So to support staff from working from home. I know this is something we're dealing with, where staff don't have adequate equipment at home to work from home. And might there be any support for that federally?
That is a great question. I don't know if that has been included, but I think some of the funding streams potentially the broad strokes funding streams would be able to include that, because there is usually within our victim services funding streams ability for equipment. So you'd have to ask for it right in the budget. So I can double check on that, but yes, I think so.
Would that also extend towards staff salaries during this time?
Yes, yes. Yeah, similarly, your budgets would include staff salaries. Yeah.
Okay. Could you share some funding sources for hotel accommodation in case the lack of shelter space, and also how to possibly supply food when survivors are in a hotel?
Yeah, I think Jill mentioned this, like some of the HUD funding you're able to use for those services. And then I think ESG can be used for hotel, correct me if I'm wrong, Jill, hotel, motel. And I think we're trying to make sure that the VOCA funding, you would need to talk to your FIPSA administrator and your funders, but just saying at this time we're shifting models. Like, would this be an allowable approved change for our budget? So I think it's having that conversation, like we're still gonna house X number of people. We might actually house more during this crisis, and modifying your budget with your funder. So we've heard a lot, and I've seen it on the chat room too, that folks have made those changes already and have shifted to the hotel motel and some of the separated environments, so people can less ability of the disease to spread.
Great. And this is for whoever would like to take it. There's a question about any advice on how to support transient minors and youth, especially in conveying the importance of the situation. It's a hard one.
I think Lish might be talking, but she's still muted.
So I actually somebody was asking me to answer a written consent question right now somewhere else. So I said in 30 minutes, but that meant I missed the question. So I got nervous. It was aimed at me. It was like a school nightmare all over again.
No, this is about working with transient youth and sort of how to house them, which is already a challenge outside of this virus. And especially talking to them about the importance of addressing the virus and staying safe.
So I don't have anything specific about transient youth, but I do think that we just keep asking ourselves the question, what, if anything, is actually different because of the COVID-19, right? Transient youth are exposed to hepatitis, they are exposed to HIV, they are exposed to the flu, they are exposed to the vulnerability to trafficking. So there's a lot of things. So I think that there are a lot of things that are new and different because of this pandemic, but there are a lot of things that aren't. And so you can tell where my safe space is. I just go back to, okay, where do I start from? Does this situation actually change anything? And if it does, what does it change? And then address that specifically. That's what I do when I feel kind of overwhelmed and not sure what to do next.
Great, thank you. We have a question. Are providers working directly with their county and state emergency operations centers to get additional resources?
Carla, I wanted to jump in real quick on the,
Absolutely.
The youth question.
Please.
So in some communities, there are youth demonstration projects. Increasingly so, a lot of communities have those. I would investigate whether you have those programs in your communities, and they might be able to provide you some resources for youth at this point.
Thank you, Joe. And those have 21-day limits, is that correct?
That sounds like runaway homeless youth. The youth demonstration projects are really designed to get youth in more permanent types of housing.
Okay.
So they would be longer than 21 days.
Okay, thank you.
Sure.
Okay, so I will go back to the other question. Are providers working directly with their county or state emergency operations centers to get additional resources?
I mean, I'll just answer really quick. I've heard from a lot of communities that there's increases in state and local funding as they're addressing this pandemic. And so in addition to doing your services, definitely being at those tables where those decisions are being made to make sure that that domestic and sexual violence providers are part of that conversation and getting access to those resources. So definitely it's a time to reach out to your county's funders. And I'm sure that's probably happening in Washington State, California. I'm hearing lots of big increases in funding. So I think it's very timely. So before things have passed, try to get to your county funders now and start planning.
That's excellent advice, Debbie. Does anybody have any info on waiving limitations related to economic assistance for immigrant survivors, those with or without immigration documents?
I can share one thing. I'm Hyun from Continuum, Illinois. Actually, you know, we are because of the staff capacity. I mean, the packed in the office, so we are kind of by turn remote. You know. Working from home. And before we released last Friday, we checked all the clients, you know, status very keenly, if they have emergency contact or not, or they have a medical insurance or not, or, you know, car available, or children's age, if they need diapers or, you know, kind of food, including dietary, all very specifically. And we realized that even though there is a getting fund takes time, special fund takes time, and even though we have fund, it's very you know, surviving essential stuff, they cannot get it, you know, right? You know, even though people are in the line to get stacking, you know, supplies, they don't know what to do, and then they didn't have chance to get it. So we realized that this is so emergent situation, and then we started a campaign called Share One campaign, and we reach out community and donors, supporters that, you know, sharing, you know, like one item. We checked all our clients culturally, and then, you know, specific needs, and then there is a toilet paper, you know, paper towel, you know, kind of feminine hygiene products, hand soap, sanitizer, diapers, and rice, instant ramen or canned soup, pasta sauce, very specifically, and reduce the list, and then share community. So we chose 2 or 3 locations. Illinois is very long and wide, so west, east, and Chicago area, and then put you know, donation drop box in a certain location, like a church, get help with church, and then people are getting donate their, you know, one item, one of toilet paper unopened, one you know, paper towels is becoming huge. So we pick up our staff is picking up regular basis and then distribute you know, each clients, so they don't miss, you know, at least 2 or 3 week available you know, supplies, they can get it. So in this case, we had a questions about the safety planning. Actually, we are doing, you know, mobile you know, communication. We're trying to do as possible, you know, as safe as possible. But, you know, in case the clients who is living with their abuser and kids, is really hard to even communicate and let them out, or, you know, pick up, you know, their you know, necessities or supplies. So yeah, I wanted to share our Share One campaign. I think it's very effective. People are community members, even though they are kind of you know, scared and stressful situation, they're willing to share. So they want to, you know, drop the supplies in the box. But at the same time, you are kind of worried, how can we, you know, if the clients are living with the abuser, is really hard to, yeah, figure it out. Yeah.
Thank you so much for that. Let's see here. Apologize. Another question ready? Okay. So there's a question about law enforcement responding to domestic violence in the community, I would say, and or even sexual assault when the community is in quarantine and the officer doesn't want to transport offenders. Are there any thoughts on that? Feels like it's the same response that we have throughout, right?
Yeah, I think it's just figuring. These are things where people are, things are rapidly shifting and changing, but criminal justice responses are definitely shifting in communities, and actually, there's quite a few communities where there's, because of the similar issues we're facing, that people are being released from jail, which potentially could be somebody's abuser. So we're doing the best that we can, I think, in this situation, and just having to safety plan, and then hopefully get people to shelter.
Great, great. There was just a question in the chat that was. So if clients develop symptoms in the shelter, should we put them in hotels, and how would we transport them? How would staff transport them?
So, I mean, I think that if we have if we can get access to hotel rooms where people can be, and they can be appropriately socially isolated, then that gives them the opportunity to determine, whether they've just got a regular cold or whether it's COVID-19, but they've still got resources and a safe place to shelter. In terms of transporting them, this goes back to, this is a healthcare crisis, and so we're always connecting to healthcare workers. So if somebody's developing symptoms, the recommendations from the CDC are contact your healthcare provider, and then talk to your healthcare provider about what are safe mechanisms for whether it is going to see the healthcare provider or moving to an isolated space. You know, all the things that we've been hearing about how we function, right? Like wash your hands carefully, don't touch your face, sneeze into your shoulder. All of those things would certainly apply for someone who has symptoms, doubly so. But I don't want to pretend to be a healthcare worker. I want us to connect people with healthcare workers who will then give us the best protocols for how do we do things like move safely for a short space of time to a new location, and how do we assist people to make that happen safely.
And I do want to remind people, I just was out today for a second, like there's, in larger cities, taxi folks are still working, Uber, Lyft is still working. So we have these people in our community who I consider the backbone in our first responders, you know, like our grocery store workers, pharmacists, and taxi folks. So they're still, those people know the risk and are still doing that that work. So we can call on them to do transportation as well, and just try to follow the CDC guidelines of protecting yourself and each other when you're in space together.
Okay, there was one more question recently. When a client might be infected by the virus, our shelter protocol is to contact our local medical professional and have them assess. If needed to relocate the clients, these medical professionals will be doing the transportation or direct us how to do it. Okay, so that was a great thought as well. There was a couple questions about if you are a shelter that's sort of different, like you're operating out of a home or you mostly serve youth. How is this guidance different for those types of entities?
I think it's very similar, and I'm happy to hear from others on this too, but I think some of the same precautions that we would be taking in any kind of communal living situation, which many shelters are set up that way, we would be taking within our own homes. So I think the things, masks and wipes and washing and isolation when that's appropriate, when somebody does have symptoms. I think there are, households throughout the country right now that are dealing with someone, a family member who's sick, living with them. And so some of the same kinds of things would apply in those kinds of temporary shelter arrangements as well.
Great. Thanks, Chris. We had a couple questions around how to support staff during times like this. How to make shelter house staff feel supported and valued and safe when they are the only ones who can't work from home or have to go out into the world for their job. Many different scenarios, or have to not work because they can't work from home. Just sort of supporting our staff who work so hard and are impacted as well when still wanting to serve survivors. Even those who are working from home and doing advocacy remotely, there is a strain.
I just see Brittany's comment. Oh, sorry. Go ahead, Suzanne. I've been chatting a lot.
Oh, no, I'm sure folks have thought of this. So just specifically for the folks who are working in the shelter directly with survivors, there was a recommendation to try to go to a skeletal staff plan, and just having one staff person, there at a time, if you can do that, and for some programs, that's not a heavy lift. For others, it might require sort of shifting perspective about the kind of support that you provide, but to really keep it lightly staffed as possible and providing, like we've been talking about, advocacy in other ways for folks via mobile advocacy and things of that nature. So that's a very concrete strategy for a very specific scenario, but one that we've heard.
The other thing I was going to add, and it wasn't my idea, I think it came across a listserv and someone was telling me about it from Kelly, the Coalition ED in Idaho, was talking about like, how do we support those on the front lines? And I think, someone mentioned that those are often the people who are the most underpaid and will be impacted. So I think, we're all struggling nonprofits, like if there is money that you can give people an additional wage or bonus during this time, if there's additional funding, just thinking creative ways of like, it won't help someone if they catch the virus, obviously, but just like, what are ways that like help people meet their needs and support them? And, there's issues with childcare and those things, but like just thinking any creative thing you can do to take care of your staff and workers, because we're all in this together, I think is really beneficial. And then we also have I'm just thinking of things happening in my own community, like there's a lot of helpers stepping up. So, if you do have a volunteer base or people within your organization that have been trained that would want to step up and provide support or do different things. I know a lot of food banks are asking for people to come and like make boxes. So there is a network of people who want to help. And so don't hesitate reaching out to people, that you don't have to do it all alone within your nonprofit and just the staff you have right now.
I would echo a little bit too of what Debbie just said. This is Linda at Wiskative. In terms of supporting staff, and we know that many of them are low paid, sometimes minimum wages, and if an organization can certainly not just express the verbal appreciation, but if there's a way to add a couple bucks an hour to what their wages are, the sensitivity that there are staff that might have elderly people they're caring for. All of our schools in Washington State are closed. Staff is struggling with childcare. So what are the different flex scheduling, teamwork, skeletal staffing, what can happen so that people who simply are not able to work all of their hours or any of their hours can still be supported by that agency, whether it's food, some sort of wage, the flexibility, and realizing that childcare right now is a huge issue for us in this state.
Yes, thank you, Linda. Someone had asked, has anybody, so some residents in shelter have been asked to work from home, and they're not quite sure sort of what that looks like in the shelter environment.
That's a great question.
Yeah, so you're mentioning that staff, shelter staff, are being asked to work from home?
No, residents.
Oh.
Residents, yeah.
Residents, okay.
I'm curious. Yeah, I'm curious if anybody on the call has.
Well, we were definitely encouraged to work from home. However, that is impossible. We have clients at the shelter who have needs, who need to go to court, who need access to a computer. And so we intended to work from home. We wanted to respect our director's request of staying home, but we had to come in just to be able to give them, be able to meet their essential needs. We don't want them to feel isolated or neglected by us. And that's what happened in just one day of us trying to stay home and respect that. So we have been coming into work. We've minimized the amount of people that come into work. So we are definitely keeping staff here during normal business hours and limiting time that clients can be working with us. And so that's how we have been working. Staying home.
Well, and just in terms of that, the question that was mentioned, what about shelter residents? That's what I'm hearing, who are being asked to commute remotely to work, and just the idea that they might be able to do that. I would hope that programs would have the internet connections available so that people can do that. I think a lot of shelters are equipped so that folks are able to do things like job searches and all sorts of remote activities from their laptops at the shelter or in whatever program there might be. So I think that's just an exciting opportunity for someone to somehow retain a job and just have the privacy, and for programs to really look at how can you beef up your internet connections.
Well, and I also think I want to call out Suzanne for showing an example of it. Like, kind of all bets are off for us right now. Like, we're all working in different creative spaces. So a survivor could go outside and work and do things creatively. So there's, you know, or if there is a space where you could set up for someone could have their own office space, or if it's set up in their room, or finding donations so someone could have a desk. But yeah, however we can make sure that as many people stay employed during this crisis, like we're doing our jobs, and you know, if someone is on a call or the kids are running in the background or there's shelter people in the background, I don't, you know, like trying to find their a private space is probably best for that confidentiality piece.
And I would just add one last thing, which is it's been mentioned, you know, going back to our principles as a movement, and how important we've talked about this flexibility in how we provide services, and case by case, and survivor driven advocacy, and all of those core values really come to bear in times like this. So if it does mean, okay, no one's using this office, we will let a survivor set up camp, or let a resident set up camp in the staff office so she can, or he can do, you know, remote work. I mean, that thinking hopefully is already ingrained in the work that folks are doing, but to really put it to the test in these times.
Okay, well, we are absolutely at time. So I just wanted to thank all of our speakers and all of our participants for being here today. We know that the conversation is not over, and it is constantly changing. So we know we also didn't address all the questions, so we will do that in a follow-up email with additional resources. And I know we're hoping to do this again soon. So I guess I just want to thank everybody today. Thanks for being in community with us. Thank you for you know, sharing all the things that we're dealing with right now, and trying to stay positive and hopeful, and know that our core values will help us figure out how to handle this, because at the essence of it all, it's why we do what we do. So thanks. Have a good day, everyone.
Thanks, everyone.